a paper that I wrote because I was very disturbed by the changing way in which neoadjuvant chemotherapy was being given. I was one of the first in 1990s pusher. Let us do neoadjuvant chemotherapy. This is the way to go. This is the window of opportunity studies. And then when I started seeing evidence piling up one after the other, I said, oh, maybe we are only looking at the speedometer and not looking where the car is going. Thanks for the video. So I think that was the problem I saw. And I couldn't convince people around me, so that's why I said I must write the data. And unfortunately, I still believe that I have spoken the inconvenient truth. Right, number one, I would like to clarify the misconception. I've been given 3 or 4 minutes and not more. So, is complete pathological response related to improved survival? That's a trick question. It is related. So, PCR tells us who will do better and who will not. The same people will do better and not after adjuvant, just that they won't know that they're going to do badly and not give them bad news early. But improving PCR does not reliably improve overall survival. So that is a very important point. And this is an analysis by FDA which found a flat line for correlation between improving PCR and improving OS. There should have been an absolute curve line that way. There isn't. And we cannot predict which drug will do what. So clearly, I completely agree with Mark that we cannot use better outcome in neoadjuvant setting for adjuvant setting. So this shortcut, unfortunately, doesn't work. Second question, does neoadjuvant chemotherapy increase local recurrence rate? Well, yes, it does. I mean, there is no doubt about it. We all use the current treatment using EBC-TCG. Why this analysis is bad? And it was actually later than all the data that we use for treating our patients. And remember, the right-hand side, which is shown in the appendix, shows that if you change from mastectomy to BCS, it actually significantly worsens the local recurrence rate. Second point, this has not been said by anybody. This is a paper in Science Translational Research, and it's not in mice, it is in human beings, where they clearly showed how neoadjuvant chemotherapy evokes a tumor response, it makes bone marrow divide cells infiltrate the tumor, and increases breast cancer cell dissemination, and induces more cancer aggressive phenotype because of evolutionary pressure. And 1% difference in mortality has not been excluded in EBC-TCG. It was only 4,000 patients. So there may be worsening survival. Third, does neoadjuvant chemotherapy allow more breast conserving surgery? Yes, of course, it might. And EBCT said 10% more. Now the real life data showed in this graph shows that it improves it by 10%. And we need to tell patients there's a 10% chance of improving your breast conserving rate. But if a tumor is less than 3 centimeters, it increases the mastectomy rate. Remember that, small tumors increases mastectomy rate. And in this meta-analysis, two of them, one authored by Fiona McNeil, showed that in these 12,000 patients, if you plot increasing PCR with increasing, whether that increases breast conservation, no, it doesn't. So the fact that pertuzumab doubles the PCR actually doesn't have any value on increasing the breast conserving rate. So this is a meta-analysis, it's not yet published. You can see adding trastuzumab or adding pertuzumab to trastuzumab does not improve breast conserving rate at all. Strangely, this was never mentioned in the Neosphere paper published. And the fourth point is the last point which Mark made, is dramatic improvement in PCR do not always translate into better OS. And here we have seen Beatrice, Neo-Alto, and Affinity. The overall survival was tucked away on the page 31 of the New England Journal paper appendix. No difference in overall survival. So, unfortunately, we cannot predict which drugs are going to cause improvement in survival. And PCR rates are higher, but never approach 100%, which is achieved by surgery. People forget, 50%, so half the patients are going to sit with the cancer for 5 months. You would allow that to happen with surgery? Yes, I want to do less surgery. I've done a trial for less radiotherapy. So that is where we should be going, but this is not possibly the tool. We should think differently. That's where I'm coming from. So 46% of patients will be with their tumor, and this walking around for months is a psychological burden, which has never been addressed in any of these trials. And this is probably my last slide. I'm still looking for a magic clip, which will gather residual tumor cells around it. So only then, look at this clip. This is a magic clip. So neoadjuvant chemotherapy, most of the tumor disappears. Rogue cancer cells which are resistant remain. but this clip gathers them all around it. So now you have the perfect solution to do excision with clear margins which are truly true, and that's where, when that happens in my lifetime, I will do breast conserving surgery. I want to give one last point about the COTAS, the CREATEX study. The CREATEX study gave capecitabine to those who did not have complete pathological response. But what if they had given it to those who had it? They might also have improved their survival. And Natori meta-analysis published in 2017 found that capecitabine improves OS and DFS in everybody. So it's not just limited to those who receive no PHCR, but it has got its toxicity. Yeah, thank you.
Thank you very much, Jay. Yes, why don't you sit down and I'll stand. I've been sitting down for a while, so I need to stand now. Thank you, Jay. And thank you very much for keeping to time. I do like your pictures. And Mike, thank you for keeping your clips short but very pertinent. So we're not going to do any case discussions. Instead, we're going to throw the floor open for questions and discussions. But it's fascinating.